Good morning. My name is Jeff Weber. I am in private practice in Traverse City, Michigan. And my talk this morning is on management of rear foot and ankle non-unions. Thank you for the opportunity to give this lecture this morning. My learning objectives are to identify the risk factors for non-union, explain the role of orthobiologics in non-union management, and then identify ways to prevent non-union, both preoperatively, intraoperatively, and postoperatively. So a question that the patient asks all of us is, Doc, is my fracture healed yet? And that answer to that question is important because it determines the patient's weight-bearing status. And we know that prolonged non-weight-bearing status can lead to things like wrist and shoulder pain if the patient's on crutches for a long time. It can increase their fall risk. It can cause deconditioning and prolonged rehabilitation for the patient, and even decubitus ulcers. It can mean a loss of revenue for the patient and their family in regards to their inability to return to work in a timely fashion after a fracture or a fusion of their foot or ankle. It can disrupt planning of future life events, and it can also create anxiety over the uncertainty of whether or not the patient's going to need future surgery. From a clinical standpoint, when is a fracture or fusion healed? The most common sign, I guess, would be the absence of pain when weight bearing. The second most common would be the absence of pain to palpation at the fracture or fusion site. And then we'll talk a little bit more about radiographic imaging and healing of bones in just a bit. So I won't belabor this slide, but we know that there's a pattern to fracture healing that starts off with hematoma formation at the time of injury, to eventual deposition of new bone by osteocytes. And somewhere in this spectrum of healing, things can be halted and the bone can go on to a non-union. So one of my questions that I was trying to ask when I was challenged with creating this lecture was, is the biology of bone healing and the biology of arthrodesis the same? And I couldn't find a good answer. There's no studies within the foot and ankle literature. I looked at spine literature, which then really only looks at animal models, which shows that fusion at the microscopic level is different than fracture healing, and that there are different types of spine fusions in regards to the anatomic location of where the vertebrae is being fused. And studies show that there's even different microscopic environments amongst those different kinds of spinal fusions. And so the conclusion to this question is that this is not studied in the foot and ankle literature or even in human models for that matter. I would liken fusion to primary bone healing as opposed to secondary bone healing. We know that secondary bone healing would have callus formation and microscopic motion versus primary bone healing would not have callus formation, and that's basically what we're going for when we fuse the any joint in the hindfoot, midfoot, or forefoot. So some definitions: delayed union, absence of radiographic progression of healing fracture between 4 and 6 months after injury. A non-union is the absence of radiographic healing of a fracture beyond 9 months after injury or beyond the expected rate. A malunion is a healing fracture in non-anatomic alignment. Definitions in the literature are all over the board. Some people have suggested that a non-union can be as early as 2 months and as long as 12 months. The FDA has defined non-union in the past as non-healing fracture 9 months from the date of injury with 3 months of radiographic evidence of non-healing. And then they changed their tune after 1998, saying that a fracture that shows no visibly progressive signs of healing. I like Marsh's definition, the cessation of both the periosteal and endosteal healing responses without any bridging. Other definitions of non-union in regards to trauma, specifically viable versus non-viable non-union, and infected versus non-infected non-union. Viable non-unions and non-viable non-unions are treated differently. Viable non-unions do obviously, as their name implies, has some viability left in them that might be amenable to a bone stimulator or a prolonged course of non-weight bearing. These are hypertrophic and oligotrophic non-unions. There is questionable viability of an atrophic non-union, and then necrotic non-unions or defect non-unions are considered non-viable and often require surgical intervention. In regards to non-union rate in the hindfoot and ankle, specifically regarding trauma, this was a study published by Mills in 2017 showing that the overall rate of non-union for all fractures in the body is 1.9% versus that in the foot and ankle is 1% or less. What about non-union rates in regards to elective fusion? You can read any paper and the non-union rate will be all over the board, 0 to 36%, 10 to 11% average. For the subtalar joint, 0 to 25%, average time to fusion of 3 to 4 months. Also of note in this paper in JFAS in 2013, no significant difference between union and non-union rate with 1 versus 2 screw fixation of the subtalar joint. In regards to non-union rate of triple arthrodesis, 27% non-union rate, the talonavicular joint being the most common to go on to non-union, followed by the calcaneocuboid joint and then the subtalar joint last. Ankle non-unions reported at 0 to 40% with an average time to fusion of 10 weeks. This study, I drew these conclusions. The hindfoot non-union rate is greater than that of midfoot and forefoot. It's important to set timelines for patients for realistic return to activity and work and their weight-bearing status. You have to have post-op protocols in place depending on what joint you're fusing. So if you're fusing an ankle, the post-op protocol can be vastly different than that of fusing the first metatarsal phalangeal joint. And also finally, the common dictum of 6 weeks to fusion doesn't apply to the hindfoot when you look at the time to fusion. A study in the Journal of Injury in 2014 shows 100,000 non-unions per year in the US. They looked at 2 categories. 1, money spent to prevent non-union, and 2, the cost of treating an established non-union. So the next slide, in regards to money spent to prevent non-union, the study found that there was a decreased cost in patients that had ORIF tibia less than 12 hours as opposed to greater than 12 hours from the time of injury. They found 0 non-unions in those that were treated quickly within that 12-hour window versus 8 non-unions that had ORIF after that 12-hour window, a study of 35 patients. This second point, not directly in regards to non-union specifically, but in regards to faster fracture healing when using recombinant BMP2 as opposed to not using BMP2 for ORIF tibia, suggesting faster return to work if you have faster healing of the fracture. So the other thing that the paper looked at was the cost of treating an established non-union. There was a 47% cost savings when surgeons used BMP2, bone morphogenic protein 7, as opposed to the control group. They also found a significantly increased cost of treating non-union as opposed to treating ORIF tibia that didn't have non-union. It's important to look at risk factors when evaluating patients for elective surgery. This I thought was a great paper that was published by Thivendran in Foot and Ankle International in 2015. So the purpose of this was to describe and validate a non-union risk factor model. They had 62 patients, 22 ankle and hindfoot non-union, 40 ankle and hindfoot union. They looked at 19 risk factors and they weighted and categorized them. They took a survey of 100 surgeons who then basically stratified all of those 19 risk factors from highest risk to lowest risk. And then they assigned those factors a value score of between 1 and 10, 1 being a very low risk factor, 10 being a very high risk factor. And they used the standard or average number of 5, right, in between, right in the middle of 1 and 10, saying that 1 pack per day smoker was assigned a risk factor of 5, and then they stratified risk from there. So the results They had a mean TNR, or total non-union risk score, in the control group, the ones that had osseous union, of 6.6 versus 13.5 in the non-union group, which was a significant difference. They had three categories. The middle category is the one that I want to focus on here first. Risk factors where there is no different than smoking 1 pack a day, versus the column on the left, risk factors that are more significant than smoking 1 pack a day, and then the column on the right, less significant than smoking 1 pack a day. Again, a total of 19 risk factors. Those risk factors are all, again, here highlighted in red that I showed you. And you can see in the middle column the mean score that these 100 surgeons gave each of these. So the highest score was given to the 2 pack a day smoker, all the way down to the lowest score, which was a patient over the age of 60 years old. So an example here, how do you find this TNR score? A 65-year-old male, this is just my example, if he or she, he had a BMI over 40, an age over 60, and an A1C between 6.8, he would have a TNR of 12.5. So why is that important? Is that they found that if a TNR score was greater than 10, the patient would have a 9% chance of non-union, and that was validated by their statistical analysis. This study had excellent intra and intra-observer reliability. It was the first model to predict the risk of non-union in the ankle and hindfoot fusion. And they showed that there were the most significant predictors of non-union were obesity and lack of fusion site. The end goal is to generate some sort of a computer risk model that's easy for the foot and ankle surgeon to use, very similar to that of already established fall risk, or VTE, scores that are in place in hospital settings. So, do or should risk factors change your pre-surgical plan? The answer is yes. Smoking cessation and counseling should be given to these patients preoperatively, even go so far as to make sure that the patient has a negative nicotine test, especially in the setting of an elective fusion of any joint, whether it's the hindfoot, midfoot, or forefoot. We need to medically optimize these patients, particularly in regards to vitamin D levels. Anyone getting bone surgery should have a preoperative vitamin D level drawn. In my book, it's shown that non-union rate is significantly higher in those that are vitamin D deficient. If you want the formula for correcting vitamin D deficiency, it's 50,000 international units of D3 weekly for 12 weeks. Also of note is to manage these patients in the preoperative or perioperative realm in regarding immunosuppressive drugs, anti-inflammatory medications, and disease-modifying anti-rheumatic drugs to decrease the risk of non-union. You have to talk to the patient about weight management, as we know that obesity significantly increases the risk of non-union. And then vascular testing preoperatively. For anyone that doesn't have pulses, all of these patients should receive non-invasive arterial testing. Some people even argue that certain people with medical comorbidities such as diabetes or even a history of smoking with pedal pulses should have vascular testing. The key here, I think, is a checklist. This is my pre-surgical checklist that my staff and I go over to get patients to the operating room. I am guilty. I should add vitamin D, nicotine test, weight management, whether the patient agrees to it or not. At least we check off the box that I had the conversation. The vascular studies are in the chart and ready to go. Even putting a checkbox for making sure that the patient has all of their DME picked up so that they can leave the surgery center safe and non-weight bearing. And even maybe perhaps a checkbox for patient compliance contract where they sign something saying, I am agreeing to the fact that I acknowledge that I will be non-weight bearing for an extended period of time. Just things that you can do with the patient to get them optimized preoperatively, understanding that they're going to be non-weight bearing, so that compliance will lead to an optimal outcome for the patient and decreased non-union. Other questions, so do risk factors change your surgical plan? For example, prevention of non-union. I do want to talk about autograft and allograft biologics and different fixation constructs to prevent non-union. A little wordy on this slide, but each bullet point is a different study. So Daniels, in 2015, a level 1 study showing recombinant PDGF with tricalcium phosphate combination versus autograft. The biologic combo was as safe and effective as autograft with no donor site morbidity. Weinraub, 2018, no difference between use and non-use of biologics in triple arthrodesis. DiGiovanni, 2016, if you have 50% graft fill at 9 weeks on a CT scan, regardless of what graft type you use, there is a significantly higher chance of fusion at 24 weeks. We, in 2017, similar fusion rates in foot and ankle surgery comparing autograft versus allograft. In regards to preventing non-union, intraoperatively, joint prep, Weinraub in 2018, combination techniques had significant decrease in non-union rate, 26% versus 75%. Curettage and fish scaling, better than fish scaling alone. No difference in joint resection versus no joint resection, no difference with curettage versus no curettage. Yoshimoto in 2020 basically said to always prep the subtalar joint if you're doing a TTC fusion. They found that there was a significant increase in non-union of the subtalar joint. So take the time, prep the subtalar joint. We know that we're blasting through the subtalar joint with the reamer. It doesn't give an excuse to actually go back in there and actually scrape out what's left of the cartilage in there to optimize the patient for success. In my hands, I use a curved curettes, osteotomes, followed usually like by a 2-0 drill bit with a soft tissue protector and then fish scaling thereafter. I started looking up literature for you all on bone stems for preventing non-union. There's so much data to suggest the use of bone stimulators. I'm not going to go into a hefty lit review on this. They do work. If you're trying to get these approved prophylactically, I don't think that's able to be done. If your facility is willing to eat the cost, you're lucky. If you want to put one on after a fusion, or maybe fortunately the patient already had one if they're having a revision. Other things to look at preventing non-union fixation construct, Preisel and the Columbus group in 2017 we're looking at ankle arthrodesis, no difference in non-union with an anterior plate versus the traditional cross lag screws. Mitchell in 2017, no significant difference, but there was a trend toward improved fusion with the plate lag screw construct as opposed to just the traditional lag screws alone. Ficcieri in 2019, they were looking at fibula fractures, no difference between locking versus non-locking constructs for that fibula plate, alluding to the fact that, yeah, non-locking plates are cheaper. If you're going to use that in the ASC setting, save the money. Diagnosing non-union physical exam, continued pain and motion at the fracture site or fusion site, persistent swelling, infection at the fusion site would allude to the fusion going on to non-union. There are lab values that you should look at for infection, ESR and CRP. If you didn't look at it preoperatively, you should look at it now, but look at the vitamin D level, especially if you're not seeing signs of healing on radiograph. Diagnosing non-union with plain film radiographs, it's sometimes difficult. The hardware is in the way. The x-ray tech might not have the right angle for you. But if you see a persistent fracture line or persistent joint line, if there is lack of osseous bridging or progressive deformity or hardware loosening, those are obvious signs that the patient is going on to non-union. CT scan is the most sensitive test, obviously much more sensitive than plain films. It's expensive and there's radiation exposure for the patient. If you are suspicious for infection, you can order these combined scans, a SPEC CT with a WBC scan or a sulfur colloid scan with a WBC scan. MRI has limited use, especially in the setting of hardware. There's a lot of artifact, although now there is some software models to mitigate the amount of artifacts that we see on the MRI when there's hardware involved. If it's infected non-union intra-op, this is pretty obvious. Take cultures, send a piece to path, although there's some questionable reliability about the pathologist being able to diagnose this. Other studies, Jan in 2020, now we can even look down at the RNA or DNA level to look for bacteria, or to even look at different gene expression in the bone environment of the non-union to see if there is infection in this area. Non-operative management, this is a waiting game, painful for the surgeon, painstaking for the patient, waiting, using a bone stimulator, extending their non-weight bearing. You might be seeing lack of healing, and then you go back and address the risk factors that you probably should have addressed preoperatively: tobacco abuse, their A1C, and their vitamin D. As far as operative management of non-union goes, the important questions to ask here: why did this go wrong in the first place? Go back and look at the risk factors. When should I take a patient with a non-union back to the OR? That's certainly patient dependent. I mean, looking at the literature, time to fusion varies. It's longer than 6 weeks for sure. Probably looking around the 6 to 9 month mark of taking these patients back to the OR after their first surgery. So I have a couple cases. This first one is not mine. You can see the reference down below, Dr. Latt et al., the revision TTC, arthrodesis with a pseudoelastic intramedullary nail. I wanted to show a case like this. I have not used this device yet. It's nice to see the technology from someone else, though, being used more frequently. I was unfortunately not able to get this device approved for a certain patient situation at our local institution here in Northern Michigan. Hopefully in the future, though, as it's certainly indicated. But regardless, this is an 80-year-old diabetic male, previous smoker, previous successful ankle fusion, underwent revision 1 year after subtalar joint fusion, and had failed that subtalar joint fusion and ended up with what we are calling the pseudoelastic intramedullary nail, with cancellous bone chips and BMA from the iliac crest. Look from left to right, the non-union of the subtalar joint, which was painful for the patient, removing those 2 headless screws and inserting the pseudoelastic nail, which has a nitinol component running up the center of the nail, which allows for continuous compression across 1 or 2 joints if you need it. So a good option. A good bailout option for the surgeon who needs this type of construct, but again, very expensive to use this product. Case number 2 is a non-union for an ankle fusion. This gentleman was 70 years old. He had arthritis of his subtalar joint, which was fused primarily, and that healed uneventfully. He then unfortunately suffered an ankle fracture, which had ORAF, and then a while later had post-traumatic arthritis. The patient elected for fusion as opposed to total ankle arthroplasty. The index procedure for ankle fusion, allograft was used, had all 3 components: conductive, inductive, and osteogenic potential with bone marrow aspirate concentrate. Went on to a non-union, which ended up with an intramedullary nail. So here, the critique, no lag screw, although, the studies that I showed earlier suggested that there is no difference in fixation construct. So tough to say why this patient went on to non-union, not diabetic, non-smoker. Regardless, ended up doing a TTC fusion with an intramedullary nail and some biologic packed into the graft. This case was one that I presented at the residency competition back in 2014 at our MPMA conference. This was a 38-year-old female with a trimal fracture that went on to non-union of that medial malleolar fracture. Critiquing that medial mal, not sure why that wasn't tension banded at the time, possibly the cause of non-union. I do believe that this was a high energy trauma. High energy traumas do have a propensity for non-union because of compromised soft tissue envelope. Regardless, the medial mal was revised. What we ended up doing was removing all the hardware, performing somewhat of a vertical osteotomy through the medial mal and sliding it down inferiorly. It's maybe a little washed out on your screen, but the anatomy of that looks pretty good on that left x-ray. That was 19 weeks after the initial ORIF, but then regardless, very quickly went on to post-traumatic PJD of her ankle, and then she was placed into an AFO and felt that she had had enough surgery, and she's just going to live with it for a while. So my take-home points here: understand the risk factors for non-union, mitigate the risk preoperatively, optimize these patients medically, have the conversation with them, and define what a non-union is for the patient, and that it's possible that they might need more surgery in the future if they have a non-union. Get the patients a prehab consult, get them into a physical therapist to show them what true weight bearing means, and give them the reality that they will be off of their foot for a long period of time. Also mitigate risk intraoperatively, use our AO principles: rigid internal fixation, good coaptation of the joint if you're fusing it, or good rigid anatomic restoration of a fracture. Fill the joint space with something, allograft or autograft, whatever your choice is. It probably doesn't matter. Joint prep is key. Using a combination of techniques for joint prep is likely going to be more successful for you. Mitigate risk postoperatively. Choose the proper DME. Not everybody should be on a scooter. Not everybody should be on crutches. Again, that's probably where the prehab consult comes more into play. Consider a rehab facility after surgery. Sometimes it's hard to convince these people to go to rehab, but keeping these patients off their foot in an environment where they don't have the need to get up and around and do things around their house will help optimize their outcome if they're willing and if insurance will approve. And then just remember that fusion takes longer than 6 weeks. The healing of a fusion is likely different than it is with a fracture. And so you have to be prepared to extend their non-weight bearing well beyond 6 weeks, sometimes upwards of 3 months or longer. So thanks for listening this morning. I appreciate your time.